Hello everyone. Now we meet again in our third meeting with topic 10. Today we will discuss more about nutrition and cancer. Okay, I will start the presentation. Just a moment. Okay, have you already seen the PowerPoint? I will slide show this PowerPoint. Now, in this lifelong learning courses, we will discuss about nutrition consideration for patients with cancer. Okay, after 2 hour meeting before, we uh, discuss more about this. Okay, how about the learning outcome? So this meeting, we will identify nutrition and supplement needed to support the treatment. Uh, and then we will discuss what kind of how we can deliver the food or the intake to the patient with cancer. This is the reference, but you see, if you want to search more about the reference from the articles based on the previous studies, it's much better, or in other books that will uh, talk about nutrition and cancer. Okay, so this is the pathophysiology in cancer, and we will see there are many factors that affect the initiation, promotion, and the progression, and this will make the proliferation of abnormal cells when we see that cells do not differentiate it normally. So it could be a result in increased mass of cells, interference with normal tissue function, or possible metastasis. So in this point, we can see that limited fruit and vegetable consumption can be the cause of uh, the increase of mass of the cell of the proliferation of the abnormal cells. Besides the excess energy, including in here is macronutrients and alcohol. So we can see that if a person who have a higher body mass index or have a higher fat total fat in his or her body could be initiation, promotion, and progression of the abnormal cells. Besides that, chemicals or carcinogens that will also include in our daily food, like processed food or food with the color additives or any other additives could be carcinogens that will make the increasing of the proliferation of abnormal cells. How about the management? Management, we divide it into the management of the medical and also the nutrition management. And our principle here is to prevent or correct nutritional deficiencies and minimize weight loss and also maximize oral intake. Besides of that, like a previous meeting that we discussed that we can choose the artificial uh, uh, nutrition intake like enteral nutrition or parenteral nutrition. American Institute for Cancer Research guidelines for cancer prevention also mention that choose a diet rich in variety of plant-based food and also eat plenty of vegetable and fruits, maintain a healthy weight and be physically active, drink alcohol only in moderation, select foods low in fat and salt, prepare and store food safety, and always remember, do not use tobacco in any form. That is how we can prevent the cancer. Okay, now we can see that when we meet a person or a cancer patient, the first we have a step steps to decide it what the patient need and how many calories that he will take or what kind of food that we will deliver that we will give to the patient. But the first step is how we can do the nutrition screening and assessment. This is the first step when we meet the patient. So screening tools that we need is to see how how higher the risk that someone need nutrition management. There are many assessments that we can use. Some of some of them are patient-generated subjective global assessment, and then malnutrition screening tool or malnutrition screening tool for cancer patients, malnutrition universal screening tool, and ATC. There are a lot of. We can choose which one is the applicable to our patient. And then the second is to identify and evaluate nutrition problem, which we can see that individual appetite and oral intake. We can do the uh, 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 assessing. We can do the assess how many food that uh, he will see or will uh, see or he ate before, how many calorie and how can he eat it, and then we can see that how about the symptoms, is there any nausea, vomiting, and diarrhea. We also can assess the weight and the nutritional status. We can also do the physical examination. We can see the subcutaneous fat store, muscle mass, and fluid status. Mhm. By the history of his illness or diseases, we can see how many factors as comorbidities to the patient, and this become that factor that we can adjust, and also how the laboratory parameters or any other study. Now, how about the nutrition intervention? We move to nutrient intervention because we have already do the screen. Okay, so if we can see the cancer patient with the high risk of the probability have a problem with the nutrition management, so we will do the nutrition intervention by the goals. So what are our goals? Our goals are to prevent or reverse nutrient deficiency, to preserve lean body mass, to minimize nutrition-related side effects, and to maximize the quality of life. Okay, now uh, after that, we know that our goal, what will be our goals, and then we determining routes of nutrition therapy, which are oral, enteral, or parenteral nutrition. We see that oral nutrition management strategies, uh, we have to understand, uh, is it applicable to the patient or not? And then we will see how we can manage the anorexia and also alteration in taste and smell. And we also have to managing the cancer cachexia. You see, cancer may alter energy metabolism when we see the cancer patient have a highest catabolism. And then managing other cancer-related metabolic abnormalities. Okay, we can see this. There is some point here that we have to understand. First, we can see the patient's condition, and then we can see what is the candidate for nutrition support. Okay, is it if we need enteral nutrition, when we see the patient is very low in calorie intake, we can choose the enteral nutrition. Now the problem is it any contraindication to enteral nutrition? If it's no, we can start it to do the enteral nutrition. But it is if we have some contraindication to enteral nutrition, such as the patient have some intestinal obstruction, ileus, peritonitis, bowel ischemia, intractable vomiting, and diarrhea. So we can have another choice like parenteral nutrition. So in enteral nutrition, we can use long-term gastrostomy or jejunostomy. That it depends on GI function. We have to understand that our principle is gut feeding. So we do have to feed the gut. Do not depend on only parenteral nutrition if possible. Now, if we see that in gastrointestinal function is okay, normal, we can give the patient a standard formula and we can assess every 2 days or 3 days, is it adequate or inadequate? Inadequate. So if the intake of the patient adequate, advance to oral feeding. But if we can see that the patient have a feeding intolerance or inadequate, you can supplementation with parenteral nutrition and then progress to total enteral feeding. Now we can see this if there is a problem with the GI function compromise, probably uh, some cancer metastasis to the colon or in GI tract, or there is some jejunostomy or any other surgery action in this patient, we have to give the patient a specialized formula. Uh, is it a polymeric or oligomeric that is specified, easy to absorb in the GI tract? And then we can assess once again, is it inadequate or adequate? If adequate, consider oral feeding. But if it is inadequate, so we can start with supplementation with parenteral nutrition and then progress to total enteral feeding. Now, how about this? If cancer patient have a problem, so he has to have a nutrition that parenteral nutrition, so we can give the patient short term, no central access, so peripheral parenteral nutrition, or anticipated long term need for concentrated parenteral nutrition, so choose central parenteral nutrition. After that, we return to of GI function. So we can assess once again, how about the GI function? If it is okay, we oral intake is indicated. Okay. And if it is okay to the patient, you can see in a few days, 5 or 7 days, and then it advance to oral feeding. But if no, you can start to enteral nutrition. And we can see that here that central parenteral nutrition, we can assess once again written or GI function. If no, we go back to the central parenteral nutrition. So the scheme we can use to see what can we do with the cancer patient. So how about the nutrient recommendation? So for the energy, we have to estimate the energy needs of people with cancer. So if the patient cancer and he also have nutritional depletion, need weight gain, so give the patient 30 or to 35 kilocalorie per kilogram body weight per day. Okay. If the cancer inactive, non-stress, 25 to 30 kilocalorie per kilogram body weight per day. Hypermetabolic stress need more energy, so we can give the patient 35 calorie per kilogram body weight per day. And any other condition, just like hematopoietic cell transplant or sepsis. How about protein? You see this, there are a lot of conditions that related to protein. So if the patient have a catabolic state, you can give the patient 1.2 gram per kilogram body weight per day. Or undergoing hematopoietic cell transplant, so it needs a higher protein. We can give him 1.5 gram per kilogram body weight per day. So the fluid, we must ensure adequate hydration and electrolyte balance and prevent dehydration and hypovolemia. And general guidelines is 1 milliliter fluid per 1 kilocalorie total energy requirement. Just like we did yesterday in our second meeting. How about vitamins and minerals? Meet their needs to the foods they eat rather than use dietary supplement. Okay, and then supplementation or restriction of specific micronutrients might be required depending on medical diagnosis and laboratory analysis. The National Cancer Center for Complementary and Integrative Health, there is also mention about complementary therapies. With the typical, they really they have some advantages here that typically non-invasive, useful in controlling symptoms and improving quality of life during and after cancer treatment, and used in addition to conventional medicine. And also integrative medicine, just like to combine evidence-based complementary therapies into conventional cancer treatment. And then we can see here that more therapy, just like natural products like herbs, botanical, vitamin, minerals, and mushroom, and any other probiotics would help to support the cancer patient. And then also mind and body practice like acupuncture, massage therapy, meditation, movement therapies, guided imaginary, and much more therapy, just like also Tai Chi, Qigong, yoga, healing touch, and hypnotherapy. And also spinal manipulation. It's included in mind and body practice. Other complementary health approach, just like practices of traditional healers, like Ayurvedic medicine from India, homeopathy, traditional Chinese medicine, and also naturopathy. Okay, this is how can choose the macrobiotic dietary guidelines for a temperate climate, just like this. It's the same. Most of them is the same with our food pyramid. Okay, when we can see in small portion red meat, eggs and poultry, dairy, sweet, and then we go down here is more portion. We can see the whole grain is better. 40 to 60% of daily food by weight. And also we can have here vegetables and also pickles. You can see here pickles here. Vegetables contribute 20 to 30% of daily food by weight. Okay. And then more beans or bean product or tea vegetables. It gives some produce some macrobiotic, and then it will make our GI tract very good condition. Okay, so we move to rehabilitation and physical activity. Our focus is to rebuild muscle and regain strength and energy. You see, poor or inadequate nutrition will be result into fatigue, and also physical activity and exercise manage primary fatigue, improve immune function, and also reduce anxiety and depression, improve mood and self-esteem, and reduce symptoms. So if we combine the rehabilitation, physical activity, and also good nutrition, we hope that we can support the cancer patient. Now, after we give the patient our nutrition management, we have to do this is a must, that nutrition monitoring and evaluation. You cannot just leave your nutrition therapy only once and then you do not monitor or do the evaluation. Okay, you see, we can do the anthropometric assessment and also biochemical data and nutrition focus, physical findings and food nutrition related history and also patient history, including patient family medical history and also social history. Okay, now that's it. Okay, this is the end of our discussion. If you have any question, we can discuss it. And then I will try to reply it. I will try to answer it. And then we can meet in next our meeting. We will discuss about the case study. Okay, thank you very much. Bye-bye. Thank you. I will stop screen. Bye.